Hello, these are Flip Notes 5.3 and the first in our series on disorders. In this section, I'll talk about neurodevelopmental disorders, and then we'll get into schizophrenia and the depressive disorders. So, neurodevelopmental disorders actually encompass a pretty wide range of disorders, but we only talk about a couple here, ADHD and autism spectrum disorder. The thing they have in common is that they usually manifest before grade school. So usually when children are young, a lot of times one of the first signs is a child who doesn't start speaking at the normal time. They all involve central nervous system abnormalities in the brain, and that they alter their thinking and behavior, so it can create intellectual limitations. Other symptoms include social behaviors or issues with social interaction, keeping them from exhibiting normal behaviors appropriate for their age or their maturity level. Our first one is attention deficit hyperactivity disorder. So it could just be ADD, but it could also include the hyperactivity level. With this, there's a significant and consistent pattern of inattention and impulsive behavior. A lot of times they have problems with being organized and attention to detail. They struggle to stay focused on a task for a sustained amount of time, and they easily get sidetracked. So inattention. On the hyperactivity side, they tend to be impulsive. It's really uncomfortable for them to be still for extended periods of time, tend to be very fidgety, often unable to play or engage in leisure activities quietly, so they can't just play independently. A lot of excessive talking or blurting out, interrupting, they can't wait their turn. Autism spectrum disorder is quite a wide range, and that's why we call it a spectrum there. But it includes significant problems with social communication. Often it starts with the lack of communication in younger children, but also includes social interaction in lots of different social situations. A lot of times they have very limited and specific interests. It includes a deficit, and again, that social communication interaction. A lot of times they avoid eye contact, difficulty initiating or maintaining back and forth conversations. They may struggle with interpreting what other people are trying to say through their body language, or even just what's the word I'm trying to think of, but common expressions or sayings that they don't quite catch the meaning of. A lot of time they have very repetitive behaviors and sometimes tics, very specific interests or activities, and they want to stick to a routine. Sometimes it may be like food, that they eat certain foods on days of the week, or they just want to do things in a certain order, and then they can get very upset when those routines are messed up. Again, fixated interests, it could be something like trains or bugs, and not necessarily a bad thing. A lot of times it's they go very intellectually deep into understanding those interests. A lot of times they're very sensitive to other sensory input, like they don't want to be touched on their hair maybe. Could be something specific, like they don't like the feel of sand, but there's just different sensory things. A lot of them are sensitive to louder sounds, so a lot of times you'll see people with autism who wear the headphones in order to block out noises. So usually needs a more restrictive environment. As far as possible causes, a lot of them are related to genetics. There's genetic mutations, and it really depends what specific neurodevelopmental disorder, but there are mutations that cause some of them. And some of those mutations lead to developmental damage in their brains. Environmental exposure to toxins is one. For a long time, people thought that autism may be related to vaccines, but that has since been disproved and is considered a myth. Our next category of disorders are schizophrenic spectrum disorders. Schizophrenia used to be diagnosed as schizophrenia with specific types, but there was so much overlap that now it's also considered a spectrum. One of the hallmark symptoms of schizophrenia is the disturbances in thinking. So it is considered a psychotic disorder in that individuals who have this can lose touch with reality, but they have this flooding in their thinking. And it's not the same as with OCD, but it's often considered outside thoughts that are overwhelming them. It can lead to emotional responsiveness and outbursts of behavior. Usually onset is in the late teens and mid-30s. It's pretty rare for childhood onset of schizophrenia. Two different types. There's acute schizophrenia, where there's a very sudden onset of symptoms. However, while it's intense, it's often more treatable. Whereas chronic kind of develops slowly over time and is a lot more resistant to medication and cures. Some of the symptoms, in addition to just the scattered thoughts, are delusions or false beliefs. So a delusion is believing something that's not true versus a hallucination, which is perceiving something that's not there. Delusions are considered a positive symptom. We'll use that phrase positive and negative symptoms, and we don't mean good or bad. Positive means there's an addition of some kind of behavior. So you're thinking thoughts that are more or in addition to what a normal behaving person would think. A negative symptom means you're lacking something. So the common delusions with schizophrenia are generally delusions of persecution or paranoia. People think they're going to be harmed, somebody's watching them, they're being harassed, the CIA is out to get me. And then another common type are delusions of grandeur, where they believe that they are somebody important or that they have special abilities or they've been tasked with something important. Claiming that they're God or that they're the president or something really important. Sometimes they'll think that they're like corporate bosses. Those can be considered delusions of grandeur. Hallucinations are false perceptions, and they're considered positive symptoms as well because it's detecting some kind of sensory stimuli in addition to what normal people would face. Hallucinations are not required for a schizophrenia diagnosis. They can be vivid and clear. They can be any type, like touch. Sometimes people report feeling stabbing sensations. Some people see visual hallucinations, but the most common type are auditory hallucinations. So hearing voices. Sometimes the voices are familiar. Sometimes they're unfamiliar. Usually they're able to distinguish them from their own thoughts, though. The disorganized thinking and speech, again, part of that is that flooding of dopamine that we'll talk about with the causes, but it can affect their speech. One of the common terms that's associated with schizophrenia is word salad. So this is where their thoughts are so scattered that they may start a sentence with one thought, and before they can even finish the sentence, they've moved on to a different thought. So they're stringing together words in nonsensical ways. So I might say, sometimes it feels like someone has been pounding on my head with a hammer, and they've got all these other thoughts in between. I'll show an example of that in class. Schizophrenia sometimes is also includes disorganized motor behavior, and that's also, again, because dopamine plays a role in motor control. Sometimes they have catatonic excitement, where they're really like in a vegetative state for a while, but then they're also very restless. And then sometimes they're in a catatonic stupor, and that's where they're extremely like, don't do anything. Sometimes they hold on to like a waxy flexibility, but decreased reactivity. Some negative symptoms that occur is a flat affect, and this is where they seem like they're showing no emotion at all, just like a motionless face, lack of eye contact. They don't move their hands or heads, they don't speak, they're just nothing, and that would be a flat affect. What are the causes? There's definitely a genetic link. In the general population, schizophrenia is about 1 in 100, but when it's in your family, that increases to about 1 in 10%. Some theories are that when a woman is pregnant, that she's exposed to viruses, and then later on, it manifests as schizophrenia. The dopamine hypothesis is one of the biggest theories because it's shown to have overactive dopamine receptors. And one of the things that proves that is that antipsychotics block dopamine, and they're very successful in blocking the hallucinations and delusions. If you notice the brain scans on the right here, the schizophrenic twin has bigger I can't think of the words, ventricles. So those are the areas in the brain that are filled with fluid, and they're larger. They don't think that's a cause of schizophrenia, but more like a side effect. But because of that larger ventricle, that means there's less tissue space in the thalamus, the amygdala, the frontal lobes. So all of those tend to affect behavior and emotion decision making. As far as what is the familial risk factors, strongest if it's a sibling, especially an identical twin, but the chances of having schizophrenia are strong if it's in the family. Additional risk factors, psychological side says that stressful events can trigger it. So the diathesis stress model says that if a person has the genetics for it, then a stressful event is what can trigger it. And that's why it often doesn't show up until the late teens, early 20s, because that is one of the most stressful times in a person's life as they're coming into adulthood. So it is very hard, though, when people have the genetics. It's probably already in their family, and that makes it a difficult home life. Other factors, and again, these contribute to that stress model, low socioeconomic status, facing social adversity, because those create those stress factors that can bring on the disorder. There are links with drug use. So drug use alone will not cause schizophrenia, but drug use paired with the genetics can trigger the disorder. Our next category are the depressive disorders. Depressive disorders in general are characterized by a prolonged, sad, empty, or irritable mood, or just a change in mood overall. Because when we talk about bipolar, it's not sad all the time, it's also manic. So it's a prolonged change in mood. There can be physical and cognitive changes, but all of them prevent the person from functioning normally. Major depressive disorder, you're probably familiar with at least some. There's a sad mood, and then a term that may be new to you, anhedonia, which just means loss of pleasure in activities. Sometimes that term is used with people who are recovering drug addicts, who can no longer feel happiness because their body has kind of stopped creating dopamine, and they feel anhedonia. But depressive disorder, feelings of worthlessness, sleeping difficulties, and that can mean too much sleep or a lack of sleep and insomnia, an overall lack of motivation, weight change, and it's not always gaining weight. Sometimes it's a loss of weight. It has to be lasting for at least 2 weeks or more, and sometimes suicidal ideation is included. Not everybody who's depressed is suicidal, but it does correlate strongly with that. Persistent depressive disorder, also called dysthymia, is like depression, but it's a little bit milder and it's over a longer period of time. So often somebody who's dysthymic is functioning better, but they're feeling generally the symptoms of depression over a long time, at least 2 years. So persistent depressive disorder, the feelings of depression are persistent. Learned helplessness, we've talked about in previous units, that when somebody has multiple negative outcomes or stressors, that it causes them to believe that they're out of control. Studies show that people who have those multiple negative outcomes are more prone to depression. The example was with the dogs who, after they'd had repeated shocks where they had no control, stopped trying when they were moved to the box where they could have avoided the shocks. So kind of the same with people who felt like they had no control before when multiple bad things happened. Later on, when they could do something, they didn't try and they were helpless. So causes of depression, definitely a biological link and a genetic link, especially if it's an immediate family member. Neuroticism, negative affectivity, that means somebody who basically has a pessimistic thought pattern. ACEs, adversive childhood experiences, definitely lead to connections with trauma and depression. Cultural issues, sometimes gender problems, and we don't get into that as much in this course, but women are more prone to depression. We'll talk about in class some of the differences between depression and how it manifests in males versus females. Behavioral, we already mentioned, learned helplessness, and then a lot of depression is linked to maladaptive thought patterns, feelings of worthlessness, feelings of not being able to get out of a cycle of difficulty. Our next one is bipolar disorders. Used to be called manic depression because a person would revolve back and forth between manic and depression, but now we call it bipolar disorder. Two sides, the depression side, which manifests the same as major depressive disorder. Sometimes it shows up as being withdrawn or tired or hard to make decisions or just slowness of thought. But then it contrasts with the mania. And the mania can be elated, like very excited, very happy, very euphoric, that they just want to do something. They have a desire for action and they're hyper. A lot of times they speak very rapidly or they have these big ideas. They want to do all these fun things. And you may be thinking, well, what's wrong with that? Why is that a disorder? It's when it becomes dysfunctional. Like you want to do all the things, so you stop going to school, or a parent takes their kid out of school so they can go to Disney World for a month and they spend all their money. Or a person thinks, I'm going to buy all the books that have penguins on them at the bookstore so the penguins can be together. I saw that in a case study once. And they just spent so much money on books that were by the Penguin Press. I forget what the name of the publisher was. Penguin Books, I guess. So again, it's that it becomes irresponsible and that's dysfunctional to their daily life. But then it's followed again by the crash of depression. So with bipolar disorder, the person cycles back and forth between them. It can be anything from days or weeks to months between the different periods. And sometimes they'll even have a normal period in between. Our diagram here, we'll look at this a little bit closer in class, between bipolar 1 and bipolar 2, the two types. But with bipolar 1, a person has the more extreme manic episodes, followed by the bigger crash of major depression. Bipolar 2, it's considered hypomanic. So they do have that elevated mood, but it's not quite as big or significant as with bipolar 1. And the neurotypical is what a person who does not have a disorder has, that they go kind of up and down in their moods all the time, so it's normal to go up and down. But with bipolar 1 and bipolar 2, it's a much more significant up and down. Pretty much what I just said here. Bipolar 1, again, has the bigger, more significant manic episode, and bipolar 2 has the hypomanic, less severe manic episode. Causes with biologically, so serotonin is affected there, which we know for serotonin affects mood. One of the biggest medications that's used for bipolar disorder is lithium, which can mimic serotonin and increase serotonin levels. Definitely a strong hereditary link between depression and bipolar disorder. Childhood adverse situations can trigger bipolar and depression. Cultural norms, how well a person can behave and cope in difficult situations, that is a link. And again, the maladaptive thinking. We'll go more in depth in class to talk about causes. All right, that's it for section 5.3.